Good morning, everyone. We are here to discuss medical emergencies encountered in dental practice on the behalf of Dental Desk Academy. This is Dr. Shivangni Sarin this side. So, what will we be exactly doing today? We will be discussing how to master the pathophysiology of the medical emergencies. We will start to understand the cascade of events or why these symptoms and these triggers occur and why the medical emergency takes place. Next, we will learn to recognize the early warning signs and the prodromal symptoms. Then we will be able to apply evidence-based management protocols by the various mnemonics, which we will be discussing today. So now for the ease of classification of medical emergencies, I want you to know that there are a total of 16 medical emergencies. Now, the best way to classify them is according to the system which they mainly affect. So just for the ease of convenience, this is a trick which I do to learn how the 16 medical emergencies occur. Now, for the 16 medical emergencies, you first need to know that there are three which are from the word S. So you have syncope, seizure, and strokes. These are three S. As we know, syncope is mainly vasodilatory in nature, whereas seizures and strokes are neurological problems. Next, you have five A's. You have five A's. So you have asthma, which is under respiratory problem. You have anaphylaxis, which is under allergy. You have airway obstruction or foreign body obstruction. Then next, you have adrenaline insufficiency. And also under cardiac, you have angina and therefore MI, which is very life-threatening. So you had five A's. Next, you have five H. So under these 5H, you will have hypo and hyperglycemia. You will have hypo and hypertension. And last, you will have hyperventilation. Hyperventilation will come under respiratory, whereas the other four are mainly endocrinal in nature and also cardiovascular. And the last are C and T. So you have cardiac arrest and you have thyrotoxicosis. So this was just for the ease of convenience for you to remember these 16 medical emergencies. Now, this is the textbook Malamute classification, which says that under group A, loss of consciousness will be the main emergency. So under this, you have syncope and seizures. Then you have group B, which basically starts as chest pain or are mainly cardiovascular in nature. So you have erythemias, you have angina, you have MI. Next, you have respiratory difficulty, which will have asthma, which will have anaphylaxis, which will have foreign body obstruction, and also hyperventilation. And last, you have mainly allergic reactions, which are again localized or systemic anaphylaxis or allergic reactions. Again, this is a more critical and complete summary of the classification under Malamute. As you can see, the main ones that is from the chest pain, which is angina and MI, they are very critical. And these are the various management protocols which I will be discussing henceforth. So I hope it is very easy for you to remember now. Remember that there are a total of 16 medical emergencies, 3S, 5A, 5H, C and T. And under the headings, they come under loss of consciousness, they come under chest pain, they come under respiratory problems, and then last is allergic cascades. So before any medical emergency occurs, please understand that prevention is always the best cure. So first, how can you prevent it as a doctor or as a dentist working in a clinic or as a doctor working in a hospital or just a student? So first, please take a detailed medical history. The patient may have an earlier cardiac disease. He may suffer from epilepsy. They may be allergic to certain medications or certain food or certain dental materials. Please take a detailed case history. Next, always try to allay the fears of the patient. Do stress reduction protocol. Explain clearly what the procedure will be like. From a doctor's point of view, try to keep the procedure as short as possible. Keep it in the early morning times. Build a positive rapport with the patient. Ensure that your patient is comfortable and give adequate time to explain and do the procedure. Don't do anything in a rush. Now, next, if you feel the patient is already anxious, you can prescribe an Alprax or a lorazepam, which are benzodiazepines, which are basically pre-medication, so that the patient will have lessening of his anxiety. They'll be more relaxed. You can tell the patient to do certain breathing techniques where they can just relax, and you can reassure the patient that he is in the best care possible. Other than that, from a doctor's point of view, ensure you're following the right techniques. You're aspiring properly, you're giving slow injections, you're giving the correct LA dose, you're not overdosing the patient with any drug. And very important is that you should do continuous monitoring. Please keep monitoring the vitals, check the pulse oximeter, the blood pressure at the baseline. Now, before we go on further, I just want you to remember that this is how you will commonly manage most of the medical emergencies. There are a few exceptions, but trust me, whenever something happens, see, as a doctor, we may also panic. So I want you to remember this mnemonic sport. First, whenever an emergency occurs on your dental chair, just stop all the dental procedures immediately. Next, you should position the patient ASAP. Now, generally, the safest position is upright position, but there is an exception to it. We will be discussing henceforth. Next, you have to check whether the ABCs are intact, that is the airway, breathing, circulation. Get it all under control. Next, the best first line drug which you need to give the patient in almost all medical emergencies. Again, I am saying almost all. There is one exception to this. You need to administer the patient oxygen. And then you need to reassure the patient, even reassure yourself. Do not panic. It shall pass. It will be all right. Just don't worry. And finally, keep taking vitals and give the prompt treatment if you have the drug of choice, or call the ambulance ASAP. Now, these are the baseline vital signs which you need to take care of. You can pause this slide. So you know the heart rate will normally be between 60 to 100 beats per minute. BP is generally 120 per 80 mm per Hg. And respiratory rate is between 12 to 20 breaths per minute. Oxygen saturation in the room air should be above 95%. Temperature normally should be 36.5 to 37.5 degrees Celsius. Anything more or anything less than that is a sign of concern. So please act fast. Now, let us begin the first medical emergency, which is the most common medical emergency which we encounter in a dental chair setting. So this is syncope or fainting. Basically, syncope is a sudden or a temporary loss of consciousness. Why does it occur? Due to lessening of your cerebral perfusion or your cerebral blood flow when it falls. So let me tell you that the most common type of syncope which occurs in a dental chair is vasovagal syncope. So it's the most common, and due to this, the patient may experience a loss of consciousness. It is temporary. The other type of syncope which can occur can be due to a pre-existing heart disease, which we call as a cardiogenic syncope, or it can also be neurological in nature. That is, it can be due to a pre-existing CNS pathology, or it can stem from seizure disorder, that is loss of consciousness, is also possible after seizures. So right now I will be discussing vasovagal syncope, which is the most common dental emergency which is encountered. Generally, it accounts for 53 to 60% of the medical emergencies. So generally what happens is that the patient is already under a lot of pain. He's very anxious. The sight of needles or sight of blood, this basically causes abundant stress. Now, due to this, what will happen? There'll be an increase in the stress hormone. There'll be increase in cortisol. This will eventually lead to vagal stimulation. Vagus, we know, is the 10th cranial nerve. And once vagus gets stimulated, it activates the parasympathetic system, due to which acetylcholine will increase. And eventually your catecholamines, your adrenaline will increase. Now, in pharma, we all know that adrenaline acts on B2 receptors. Yes, it is also capable of acting on alpha-1, but noradrenaline is better. It acts more on alpha-1. It is adrenaline which mainly acts on beta-2 receptors. Now, once it acts on beta-2 receptors, what will adrenaline do? It will increase, or it will cause vasodilation. It will cause vasodilation, and it will reduce the peripheral vascular resistance. Vasodilation and decrease in peripheral vascular resistance, which will lead to peripheral pooling. You will see that in the extremities, there is peripheral pooling. Now, due to this peripheral pooling, your cardiac output will reduce. Your BP will reduce. And whenever these reduce, what will happen? Your BP will overall fall. There will be hypotension. And once there is hypotension, obviously the brain will also not be able to get its required oxygen. It will not be able to get its required blood flow. This will cause cerebral anoxia or cerebral ischemia, due to which the neurons are deprived of oxygen, they are deprived of glucose because no blood is coming, and this will lead to syncope, which is transient loss of consciousness. So, what are the clinical features? How can you recognize? So, like initially, when the patient is in a lot of stress, there will be some prodromal signs. Patient will start feeling lightheaded. He will feel dizzy. There'll be pallor. The face will become very pale. Now, you can understand that, because peripheral pooling is going to occur, there'll be cool, clammy extremities. There'll be diaphoresis. Patient will be sweating. Also, the patient may complain of blurred vision, nausea, and he may also be trying to yawn too much. He may be trying to increase his he may be trying to flush out his carbon dioxide. Now, let's say the patient passes this phase and then becomes unconsciousness. You will see that the patient will have a very low or slow pulse, which is bradycardia. Patient will have low BP. They may show a flaccidity or a loosening of muscles. Remember, there will be no convulsions. The patient will not be having seizures, but just may have experience a loss of consciousness. Also, urinary incontinence is also possible. So how exactly are you going to manage a syncope? I have told you first, just the first mnemonic which should come to your mind is sport. Stop the procedure. Next is position. So I told you for position, you will need to make the patients upright in most cases, but not in syncope. In syncope, we will do something called as a Trendelenburg position, in which basically you will see that the head will become lower than the feet. That is, head will be at a lower level, the feet will be at a higher level. This will increase the venous return to the heart. It will increase the cardiac output. And once your cardiac output increases, your BP will increase, and eventually your cerebral blood flow will become normal. And therefore, the patient will again revitalize. The loss of consciousness will abate away. Other than that, you need to administer oxygen. Remember, sport, O is oxygen. There is another mnemonic just for syncope, which I have made. It is position. So you need to administer oxygen at a 6 to 8 liter per minute if the consciousness has been lost. As I said, stop the procedure. You can also make the patient inhale some spirit of ammonia. It is a respiratory stimulant, so the patient will wake up. Just give some time. This situation is very handleable. It will become normal. You can establish an IV access if you feel that this is being too prolonged. You need to continuously observe the vitals. As you know, the patient had experienced hypotension, there was bradycardia, so you need to ensure that the vitals come back to normal. And nil per oral, that means that, do not give the patient anything to eat until the patient is fully recovered. Now, the next medical emergency which I want to discuss is hyperventilation. So hyperventilation, basically, again, it occurs when there is a lot of stress, there is a lot of anxiety, the patient panics. So what will the patient do? They will do excessive breathing. It will be breathing at a very fast, very deep rate. Due to this, what will happen? The carbon dioxide from the body will get flushed out. It will get flushed out. It will lead to hypocapnia. Hypocapnia. Because of so much of carbon dioxide being flushed out, there'll be hypocapnia. And this will eventually lead to respiratory alkalosis. Respiratory alkalosis. Now, why hyperventilation can be very dangerous? Because if it is prolonged, it can lead to neurological symptoms as well. So we know that the normal respiratory rate is around 12 to 20 breaths per minute. Now, in hyperventilation, it is more than 20. Due to this, hypocapnia occurs. And as I said, due to hypocapnia occurring, there will be respiratory alkalosis. There will be increase in pH. So as I just told you, generally the triggers are some anxiety, fear. The dentist approach is this white coat anxiety. There is needle, there is blood anxiety. Rapid respiratory rate will occur. Carbon dioxide will get flushed out. Respiratory alkalosis will occur. There will be cerebral vasoconstriction due to this. There will be cerebral vasoconstriction, and therefore the cerebral perfusion. Again, the oxygen rate, I'm so sorry, the carbon dioxide rate this time, the cerebral CO2 will fall this time. So what will you do to manage hyperventilation? Do you remember I told you that for most emergencies, we will give oxygen, but there is one exception. So hyperventilation is the exception. As I already told you, in hyperventilation, the CO2 has got flushed out. So we need to give the patient CO2 back now. We don't need to give them more oxygen. This will be toxic for the patient. So, try to again allay their anxiety, stop the procedures, talk to the patient, tell them to breathe slowly, deeply, not at a very rapid rate, which they were doing, and give them a brown paper bag, a breathing bag. Tell them to inhale within the paper bag for 3 to 5 minutes. That is, they will be trying to rebreathe their own CO2. Their own CO2 will come back to them. And this is how hypocapnia will become normal. And if you want, you can ensure that the ventilation is there. Just talk to the patient in a very calm manner. Try to allay his anxieties. Keep monitoring the vitals. Do not continue the procedure. So just remember when the diagnosis, how to diagnose it. Patient will be complaining of some pains like pins and needles. There'll be over breathing pattern. Patient will have a very high respiratory rate. They will be panicking. So you need to establish that rapport. You need to stop it immediately. So now for the third medical emergency, which are allergic reactions. So allergic reactions, basically, we all know, we read it in second year, that allergy can be of four types. Now I'm talking about the hypersensitivity reactions, not only allergic reactions. We know that type 1 is immediate or IgE sensitized, basically can be due to drugs like penicillin or LAs, local anesthesias. Type 2 is more rare. It is cytotoxic, basically to do with a lot of blood disorders. Type 3 is immune complex, where immune complex formation occurs. It occurs after several days. So there is serum sickness, there's arthralgia, there's lymphadenopathy. And type 4 is delayed or cell-mediated hypersensitivity, which is not IgE based. It is T lymphocyte based, and delayed tuberculin test is the best example. Again, you can pause this slide. But the one which we are concerned with right now is the immediate IgE type, because again, as I said, local anesthesia may be a predisponent to cause this. So what are the common triggers in dentistry? What exactly is allergy? So allergy, we know it is, a sudden, severe, life-threatening systemic reactions which can occur within seconds to minutes of the allergen exposure. And you need to have an epinephrine, you need to have adrenaline to combat this situation as soon as possible. Now, what are the common triggers in dentistry? They can be penicillin, which we generally prescribe. There can be cephalosporins. There can be gloves. It can also be local anesthetics. It's not due to the LA drug. It is due to the preservative in it, methylparaben. And then again, NSAIDs or your aspirin, various drugs can cause it. So what exactly is the cascade or the pathophysiology in an allergic or an anaphylaxis reaction? Generally, what happens due to a previous allergen exposure, your mast cells or basophils are already sensitized. So they haven't acted yet, but due to a previous exposure, they're already sensitized. Now, if there is a subsequent exposure, there is a second exposure, these mast cells will just degranulate, they will rupture, and they will release histamine, they will release prostaglandins. These histamine release will lead to these immediate, or it can also cause localized systemic reactions. So now let's say if it is just a localized reaction, the patient will show itching, there'll be redness. This is still manageable. For a localized reaction, you can simply give an oral diphenhydramine, which is an antihistamine drug. Now, let us say it is delayed systemic. Delayed systemic, you can again give some IV or IM phenylephrine injection, or you can give diphenhydramine, injectable antihistamine. That is injectable antihistamine you can give. Now, you must have heard about injection able. This is the case where you will give it. Now, the most cause of concern here, the most dangerous one, is the one with immediate reaction, immediate and systemic. Systemic means it's not just going to be local, it's going to act all over the body. So what will it do? Due to acting on the respiratory system, it will cause bronchospasm. There'll be difficulty in breathing. There'll be dyspnea. In cardiovascular, because it causes vasodilation, there'll be a fall in BP, there'll be severe hypotension. If it, again, as I said, cutaneous localized, it might, lead to urticaria, it might lead to pruritus, itching, flushing. And GI, it can lead to cramping, severe diarrhea. Now, as I have just explained how these anaphylaxis, how the clinical features look like. Also, one more anaphylaxis type that you must know is biphasic anaphylaxis, in which the symptoms will cause recurrence. So such cases are very dangerous. You may feel that you've treated it, but again, they may recur within 3 days. So, you need to be very mindful about such cases. And as I told you, it is basically the, immediate systemic ones which you need to look out for, because they will cause multisystemic, suppression of your multisystemic, that is respiratory. They'll cause bronchospasm, and they may cause fall in BP. Now, for the anaphylactic shock, the best management which you can learn is AEIOU. This is the best way to learn it. So, see, in a immediate systemic anaphylaxis, what is happening? The patient is having an allergic reaction immediately. I hope this mnemonic just springs to your mind if something like this happens. First, give them an albuterol, which is a beta 2 agonist, so that the bronchospasm can ease off, the patient can breathe again. Next, the first thing which you should actually be doing is epinephrine. So this, if you have an EpiPen, this is generally 0.3 mg IM, that is in 1:1000 ratio. You need to administer this as soon as possible. If you can administer IV, or it is also, you can do it, but IV may cause erythemia, so it is better to go for an IM route in this one. Uh, Next, if you want to give something IV, you should give the antihistamine, diphenhydramine injection, or chlorpheniramine injection, whatever you have with you. Next, you need to administer to the patient oxygen, obviously, and you should call the ambulance as soon as possible. So, as I have just explained, that AEIOU is just a basic mnemonic of the drugs which you need to remember. Practically, you need to do the sport again. You need to stop the procedure. If the patient is having a fall in BP, you can again do a Trendelenburg position, or you can place supine upright. You need to open the airway. You need to give the high flow oxygen. As I said, injecting epinephrine 0.3 to 0.5 mg IM, 1:1000. Please remember this. 0.3 to 0.5 mg IM, 1:1000 epinephrine. This will be the lifesaver drug. Okay. And you will be giving it IM. You will be giving it in the anterolateral thigh. You can repeat this 5 to 15 minutes. If the symptoms persist, as I said, do not give IV. You should give it IM, because erythemias may occur if you give in IV. You give in injection adrenaline IV. So, erythemia, there may be a risk of erythemia. This is again a very important MCQ. So just give IM at the moment and keep repeating until the vitals stabilize. Next, the medications, as I already told you, antihistamine IV, diphenhydramine 50 mg, also for sustained effect, so that the biphasic recurrence doesn't occur. You need to give a long acting drug. Now you know that IV antihistamine, they're going to act very quickly and they're just going to go. So you need to give a hydrocortisone 100 mg, which is a steroid. It is a corticosteroid. You need to give this to prevent that biphasic recurrence, which can occur within 3 days of span. Also, as I told you, you can give an albuterol, or you can give an aminophylline, which is again to combat the bronchospasm. The aminophylline dosage is 10 mg per kg body weight. And please keep monitoring the vitals constantly. Activate the emergency services and immediately transfer to a hospital. Call the ambulance as soon as possible. Now, another thing which can occur is asthma. The patient may have a previous history of asthma. So, always tell the patient to, carry their albuterol or salbutamol puff or inhaler with them. The cause can again be due to anxiety, or it can be due to a very cold temperature, or the patient may have just exercised, or an allergen exposure may also cause asthma. Now, what exactly is asthma? It is basically generalized smooth muscle contraction in the bronchioles, which not only causes bronchospasm, it will also cause increase in mucus secretion. Due to this, the patient will have difficulty breathing. There'll be wheezing, constant wheezing sign, which is very pathognomic for asthma. So the drug of choice is the selective beta 2 agonists, that is your salbutamol, albuterol, etc. Now, next is about your aspiration or foreign body obstruction. Now, what exactly is foreign body obstruction? This is the next medical emergency you are talking about. So see what happens in a dental setting. This is again very common. If you're not using a rubber dam, or you have not tied your dental material with the floss, because what happens, there are a lot of dental materials which can be aspirated. For example, some crown, some cement piece, some burr, some endodontic file, some bridge, wires, ligature wires, your brackets, all these have a risk of, causing aspiration. Now, aspiration is generally when your inhalation of your small object into the lower respiratory tract. This risk especially increases when the patient is supine, or, they were sedated, they had a open mouth. So now what will exactly happen? Also, one thing which you should know, that the risk of foreign body aspiration is more in the right lung than in the left lung, because your right main bronchus, it has a shorter, wider course. It is also more vertical. Whereas your left bronchus, it has a very longer course. It has an oblique, more horizontal course. So, the risk of FBO, foreign body obstruction, is more in the right bronchus. So just for your knowledge, this was there. Now the pathophysiology. Now, once this object will just enter, How will you recognize the symptoms? The patient will start having a very weak, ineffective cough because the patient will try to flush this piece or dental material out. Now, the cough will be weak, it will be ineffective. Also, there may be a risk of pneumonia or atelectasis, that is, your collapse of lungs may occur. So, you need to be very mindful when you're doing such procedures. The next symptom which will occur will be stridor. So, this will be a crowing sound. And, this is how the patient with the airway obstruction, this is the classic pathognomic sign which occurs. Also, as I said, there'll be a crowing sound, the stridor. The patient will be trying to cough that material out. Now, if such a case happens, what will you do? Immediately position upright. You'll try to, you'll give back slaps. You will encourage the patient to cough it out. If it's a child, you can hang the child upside down, and you can again pat the back of the child to enable him to flush it out. Also, only if you are trained, you can give a finger swipes into the oropharynx region. You can try to take it out, but again, only if you're trained. But if you have a Magel's forceps or a laryngoscope in your dental setting, this is the best thing you can do. A Magel's forceps, you can just try to take out the dental material piece. Now, if you are trained, the best thing which you can do for an adult patient is the Heimlich maneuver. I will just be explaining it in the next slide. Now, if the airway is compromised, please don't waste your time. Give oxygen. Immediately call the emergency services, call the ambulance. You can refer them to an ENT, but don't attempt blind removal. Don't do the finger swipes if you are not trained for the same. So as I told, you will give back blows in an adult patient, and then of course you have the Heimlich maneuver. So the Heimlich maneuver is a life-saving maneuver. Now, what exactly are you going to do? You're going to take one palm and you're going to take the other palm like this. In this xiphoid region, you're going to tell the patient to bend. You're going to go behind the patient and you're going to give strong thrusts. Now, these thrusts, as I said, they have to be in the xiphoid region. You will give upward and inward thrusts. Upward and inward thrust, you'll go behind the patient. Basically, what you are going to do, you're going to try to compress the lungs against the rib cage, and you're going to try to use the residual air in your lungs to flush out, to expel out that foreign material. This is the basis of Heimlich maneuver. Please remember, you'll go like this. You will place the pressure firmly in upward and inward thrust movement, upward and inward thrust movement. You'll try to use the residual air of the lungs. You'll try to increase the air pressure in the lungs and try to make the patient expel it out. And this is what you'll do for a baby or a child. You can, just make them hang upside down. You'll try to use gravity, and if again, none of these are acting, please call your ambulance services immediately. So to prevent a foreign body aspiration, because it's very difficult to manage the same, please ensure the 4-point prevention strategy as a dentist. Use the rubber dam isolation, which is the best and primary barrier. Use suction, use retractor. You can try your instruments with the floss before intraorally using. You can use a tray or a gauze to, maintain your operative field. Okay, so this was all about foreign body obstruction. Now let us talk about cardiac emergencies. So as I said, you have a lot of type of cardiac emergencies. There are going to be 3, which we are going to be discussing mainly. It's going to be your angina pectoris, your MI, myocardial infarction, and your cardiac arrest. Arrhythmias can also occur, but we'll not be discussing it at length today. Now, first is angina, which is basically reversible in nature. Why it occurs? Because there is an imbalance between the demand and the supply of the oxygen to the heart, to the myocardium. So what will happen? The patient will start experiencing a heaviness, a squeezing, chest pain. This will, as I said, it is reversible. It is still manageable. No necrosis has occurred yet. This pain or the chest squeeziness which this patient will exhibit will be substernally or retrosternally. And basically, this occurs because there is a fall in the blood supply causing a transient myocardial ischemia. So there is this chest pain, there is heaviness, squeezing substernally, and this pain can also be referred to your left jaw, to your left shoulder, to your left forearm also. Now, what are you going to do if something like this is happening in your dental chair? Remember, no tissue that has occurred. It is very much reversible. You're going to give a metered sublingual dose of glycerol trinitrate or nitroglycerine. You're going to give it every 5 minutes. You're going to keep monitoring until the vitals are stable or the patient feels better. This is a 0.4 mg metered dose which you place sublingually. Now, The other thing which can occur, which is much more dangerous, is myocardial infarction. Now, this, let me tell you, is irreversible. It was when that imbalance occurred for a way too long time, and now your myocardial tissue is dying. There is tissue necrosis. There will be a Levine sign characteristic. There'll be lactic acidosis, and now this is going to be very irreversible. It can cause permanent tissue death. So there is a mnemonic for angina pectoris and also for myocardial infarction. Of course, you have to activate the medical emergency services. You have to call the ambulance whenever you see such things happening. But at your level, what can you do? So for angina pectoris, please remember the protocol ONA. ONA. Give oxygen, first of all. As I said, nitroglycerin 0.4 mg, sublingual metered dose you have to give. You can keep repeating it 2-3 times every 5 minutes until the vitals become stable. And next, you will give aspirin, because you know why this was occurring in the first place. It was occurring because there was a clot, there was a thrombus, which led to your imbalance between the oxygen demand and the supply in the heart. So you'll give aspirin for that antiplatelet clot dissolution action. Okay, whereas for MI, which is more permanent, which is having necrosis, it leads to total occlusion. Generally, it occurs in the LAD artery, that is left anterior descending artery of the heart. In MI, you will have crushing chest pain. It can radiate. There'll be an anxiety, sense of doom. The patient will be able to. He may be panicking, may not be able to breathe. There'll be respiratory dyspnea. There'll be profuse sweating. Sympathetic activation overload is there. The pulse will be irregular. It can be tachycardic, bradycardic also, or may present as arrhythmias. The patient may have altered consciousness. There may be confusion, restlessness, and eventually there'll be loss of consciousness. There will be shock. Now, for myocardial infarction at your level, please remember MONA. So to the original angina pectoris mnemonic, you're going to add morphine now. Morphine is a painkiller. As you can see, this patient is having severe pain. There is this sense of doom. You need to combat the pain. So add morphine. Other than that, call the emergency services as soon as possible. Nitroglycerin, you can repeat it up to 3 times at every 5-minute interval. So I have already told you the aspirin tablet can be between 160 to 325 mg chewable tablet. It should not be swallowed. It should just be chewed, because we are trying to bypass the first pass metabolism. And position wise, again, you have to just place the patient supine, but you can also place them semi recumbently if he is showing signs of respiratory distress. Other than that, the sport mnemonic still holds: stop the treatment, position, etc. Just remember this ONA and MONA for specificity. Now, next, let us talk about adrenal insufficiency, which is again a common medical emergency. Now, what we should know, that there is generally a general HPA axis which occurs in our body. It gets activated when the body faces stress. So what happens, like if there is any sign of stress, your brain, your hypothalamus gets activated and releases corticotrophic releasing hormone, CRH. Once the CRH is released, it will further go on to activate or stimulate the pituitary gland to cause the release of ACTH, adrenocorticotrophic hormone, ACTH. This ACTH will go on to stimulate your adrenal cortex, which will release the cortisol, and this is how your stress is managed. So there's this internal cascade which is generally going on in your body when any stress presents. Now, let us say a patient comes to you in a dental setting, and this patient is already taking corticosteroids. So there is a rule of twos, which is very important in dental settings for corticosteroid taking patients. Now, what does that rule of two says? It says that the patient has had a habit of taking exogenous corticosteroids. Now, what exactly is this rule of twos? So it means that this patient has been taking the equivalent of 20 mg cortisone daily for the past 2 weeks, and within 2 years of any treatment, specifically in relation to any dental treatment. So please remember, within the past 2 weeks, 20 mg cortisone has been taken daily, and this the patient has been doing under the past 2 years. He has been having a habit of this. So what are you going to do? So the thing is, if such a patient comes to your dental setting and you have told him to stop these exogenous corticosteroids, and the patient starts feeling stressful in that dental chair, he starts having anxiety, the internal HPA axis, which I have showed, of which the chart I have showed, this will not be able to work. So what you need to do in such a patient, you can just simply prevent the adrenal crisis or adrenal insufficiency from happening. What will happen if this adrenal insufficiency happens? There will be shock. There can be loss or fall in BP. There can be a lot of dangerous signs. So you should not let that adrenal insufficiency happen in the first place. So if the patient has, he comes under this rule of twos, that is, he has been taking corticosteroids, you cannot rely on his internal mechanism acting. So in such a case, what will you be doing? You need to tell the patient to continue his exogenous corticosteroids on the day. And also, according to your general medicine specialist, you can just talk with them. If it is possible, they may also increase the dose in certain cases. But yes, do not stop the exogenous corticosteroids if the patient comes under the rule of twos, because this internal mechanism of the HPA axis will not be acting normally because of the exogenous corticosteroids he has been ingesting. So yeah. Now the next emergencies which we will be talking about will be the the other endocrinal ones, which are diabetic emergencies, which can be hypo and hyperglycemia. Now, first of all, hypoglycemia, it will occur in which patients? So it can occur in a patient who has juvenile diabetes and he's missed his meal, or he has insulin-dependent diabetes mellitus and again has missed his meal. So what happens, like again, being so tired, having a long dental appointment, this patient may start presenting some signs. He may have tremors, they'll be sweating, he'll be feeling very cold, very irritable, very hungry, so these are the signs that's why we always say that in a dental setting, always have your meal, never come empty stomach. So if such a thing happens, if the patient is having hypoglycemia, what will you do? If the patient is conscious, just you can tell them to ingest some juice, some orange juice or some glucose candy immediately. But if the patient is unconscious, you will be giving a 50% dextrose, which you can establish via IV line. Or if the patient is unconscious and you don't have dextrose, you can give 1 mg IM glucagon. Glucagon. What does glucagon do? It will cause glycogenolysis. It will cause glycogenolysis, due to which the glucose will again become normal. So this is how you will be managing a hypoglycemia. Remember the signs you need to look out for. They may, they may be feeling very lost. There'll be loss of orientation. They may be feeling irritated. There'll be diaphoresis. They'll be sweating. They'll have tremors and circumoral tingling. So these are the signs you need to look out for in a dental chair. Now the other way, it is much less common, but again, what can happen is, due to some extensive surgery or any recent history of trauma, or again, stress, what happens if the patient has had severe fever, the patient may instead start having signs of hyperglycemia. So in a hyperglycemia, he'll have a dry mouth. He'll be feeling very thirsty, very weak. He'll feel very dehydrated. There may be this floridness of your face. There may be this redness of your face. So in such a case, what you need to do, you need to administer the patient insulin. Again, you need to, use your mnemonic sport. You need to stop all the procedure. It is, of course, less urgent than hypoglycemia. But yes, it's again risky. So you need to combat this as soon as possible. Give a lot of fluids to this patient. Give insulin. And again, activate the medical emergency services. So do remember, a pro tip for a diabetic patient, tell him to eat a light meal, reduce that high insulin dose if they're already pre-diabetic or they are diabetic or juvenile diabetes is there. Yeah. So now for the next medical emergency, which we have are seizures, which are convulsions. So seizures are these sudden, abnormal, excessive synchronous electrical discharge in the brain, too much of electrical discharge in the brain, which lead to involuntary muscle contractions. It can lead to loss of consciousness again. If you remember in the original Malamud classification, both seizures and syncope came under loss of consciousness heading. Now, the causes in a dental setting might be that the patient may already be a patient of epilepsy, or may have suffered from a recent infection or a very high fever, or may have anxiety, which may precipitate this epileptic seizure attack. Again, very important, your local anesthesia in its toxic form, it is very much possible for this LA overdose to cause seizures, to cause convulsions. So lignocaine causes CNS toxicity. Please do not take it lightly. That is why overdosing of any drug should be prevented. Again, a cause can be hypoglycemia. If a patient may be hypoglycemic and there may not be any control, this seizure-like activity or even a syncope may present. So as I said, hypoglycemia in the previous slide is very important. And again, electrolyte imbalances can also lead to seizure disorder. So what will happen generally in a seizure? So there'll be a prodromal phase. Okay, this patient may have an aura. This is called aura. He may, have a strange smell. He may be feeling dizzy. He may exhibit signs of emotional changes, but he will have an impending sense that, the seizure attack is going to occur. Generally, an aura is there. Next, this tonic phase where your body will become rigid, the jaw will become clenched. So during this phase, a tongue bite risk is very high. It's very dangerous because there's a huge indentation on the tongue then. Breathing may stop, cyanosis may occur. Clonic phase, again, those alternating contraction, relaxation movements, and foaming at the mouth may occur. And, eventually, once the seizure is over, the patient will feel very sore. He'll be very tired. There'll be a lot of headache, and, they'll eventually return to consciousness. So first, the mechanism. Why did this occur? As I said, the main trigger can be some LA toxicity or may be a pre-existing case, may become anxious, have suffered from fever. Now, what exactly due to these triggers, what will happen? See, we know that lignocaine blocks sodium channels inappropriately. Now, what have you done? You have given a LA overdose. So these sodium channels, they became blocked, and what happened was severe neural depolarization. That is too much of excitation and too less of inhibition occurred. And due to this, there was an overall super excitation. So there was an abnormal firing of your neurons. There was a synchronous firing, which led to this seizure disorder. So what will you do in a seizure? You will, again, the first mnemonic, sport. So what happens whenever a patient is seizuring, the first thing actually you need to do is you can't really stop the seizure. You need to let that seizure happen, but you need to protect the patient. So you'll obviously stop the procedure immediately. Try to, place the patient supine, or you can just position them on the side so that there is no risk of aspiration and the foaming all, it won't get aspirated. It can all get flushed out because you need to maintain your airway patency. Don't force anything in the mouth. Remove all the sharp dental instruments from around the patient. Let that seizure happen. Move the patient away from hazardous object. Try to cushion their head with a pillow, and just keep them from falling off the chair. Let that seizure period happen. Now, the drug of choice for just preventing, not preventing per se, but actually at least stopping, because you could not prevent it in a dental setting. That is why we are discussing this in the first place. Is diazepam, 10 to 20 mg IV or IM. If an IV line is there, please give diazepam immediately, 10 to 20 mg injection. Or if an IV line is not there, just try to inject them IM. Now, generally, these seizures generally last for about 1 to 3 minutes. But if they are lasting for more than 5 minutes, this is a medical emergency. It is called a status epilepticus. Try to administer diazepam and call the ambulance service immediately. So what happens? There is many people become confused in a dental setting, because what happens as a doctor, you also tend to freeze out. What happens? You become confused whether syncope is occurring or a seizure is occurring, because you see in both of them, loss of consciousness is common. So how are you going to differentiate between the two? So syncope, please remember, there are not going to be any convulsions there. Prodromal symptoms are going to be there. And, the post-ictal confusion, when the patient is emerging out from that confusion will not be there. It will be absent. Whereas in a seizure, this patient will be having an aura. Whereas in syncope, the symptoms are more physical with the diaphoresis, cold, clammy hands. In seizures, the patient will, he will feel very different. He will feel that he's having some strange smells or sights. He'll have an aura. Loss of consciousness will be there. In syncope, the loss of consciousness is less. In seizure, it might be for a more longer time. And there will be a post-ictal confusion. That is when the patient will be emerging out. He'll be confused. He'll be very disoriented. Yeah, so this is how broadly you can, differentiate between the two. Then the other medical emergency, which is again neurological, is stroke. And there is also something called as a mini stroke, which is TIA, transient ischemic attacks. Whereas a stroke mainly occurs due to CVA, that is cerebrovascular accidents. So what happens in a stroke? See, the truth is you really can't do much in a stroke, because in a stroke, what exactly happens is there is focal brain damage, because there was perhaps, some thrombosis or some embolism or some hemorrhage. I have just written down ischemic causes are 80% and hemorrhagic causes can be 20%. So what will happen? There'll be focal brain damage. Due to this, the patient may have this hemiplasia, weakness, hemianesthesia. There'll be a facial droop, there'll be an arm drift. Now, the symptoms will be according to the part of the brain which is damaged. There might be speech slurring. So, you just need to call an ambulance as soon as possible. You can give the supportive treatment, you can give oxygen, but you need to activate the emergency services immediately. You need to just give the supportive patient, you need to shift the patient to a hospital as soon as possible. Okay, so now just a basic emergency kit which we need to have. You can remember it by the mnemonic oxygen. You need to have an oxygen, obviously, in your dental setting. You need to have, oral airway suction equipment. If anything like this happens, you need to have all the important emergency injectable medications like epinephrine, which is a lifesaver in so many of these medical emergencies. You need to have a 1:1000, 0.3 to 0.5 mg meat, epinephrine. You need to have a diphenhydramine antihistamine, you need to have a corticosteroid, you need to have nitroglycerin, you need to have aspirin, you need to have glucose, you need to have dextrose 50%. These, as you saw in all the medical emergencies, you cannot go without these. You need to have those blood sugars, you need to have, oral glucose tablets, you need to have glucagon. Emergency glucagon needs to be there. You can have juices within your clinic. You need to have all the 108 ambulance numbers, the poison control, AED, if possible, if you can acquire. You can have nitrous oxide cylinders, oxygen cylinders. You need to have IVs, you need to have fluids, needles of all the gauges. So these are the emergency drugs which are just explained. You cannot do without. These are a very basic list of emergency drugs. You can pause this slide. As you can see, epinephrine, 0.3 to 0.5 mg, 1:1000, which can be given IM or subcutaneously. Do not give IV because you can cause the risk of erythemias. Very important for anaphylaxis, for asthma, so many other things. Diphenhydramine for allergy, albuterol for asthma, even anaphylactically caused bronchospasms, nitroglycerin for preventing angina, for MI, aspirin for suspected MI, glucose for hypoglycemia, oxygen for most emergencies except hyperventilation. You also need to have a brown paper bag, by the way, in your emergency setting. And as I said, other than that previous slide, you can just pause it. Please remember these values: nitroglycerin 0.4 mg meter dose, aspirin 160 to 325 mg tablets, oral 15 to 20 grams of glucose, oxygen 4 to 6 liters at least per minute. You may have to increase it to 6 to 8 or 8 to 10. You can just pause this slide. Diphenhydramine idle is 50 mg, at least 25 mg you should have. You should have an albuterol or a salbutamol inhaler. You can pause this. You can see the route of administration. Other than those, if you can also have glucagon 1 mg for giving IM, so that if the need be, you can induce glycogenolysis in a hypoglycemic patient when they're not responding to glucose. You need to have a hydrocortisone because I told you for the recurrence of anaphylaxis, hydrocortisone, or for adrenal insufficiency. These are very important. Atropine you need to have to induce, to treat bradycardia, to treat hypotension also. You need to have atropine. You need to also have nifedipine if in case hypertension occurs in your dental setting. You need to have midazolam, you need to have diazepam for seizure disorders. Other than that, as a dentist, you need to be constantly CPR trained. So if cardiac arrest occurs, cardiac arrest can also occur due to various reasons. It is a very predisponent, it is a much more severe form of MI. In your cardiac arrest, you will not be getting any circulatory response. There'll be an absence in carotid pulse and femoral pulse. Respiration, there may be no thoracic, no abdominal movements. And cardiac arrest, again, you need to do CPR immediately. So you need to be BLS certified, trained. You need to have a basic life support training. It is very much required. Now, if CPR needs to be done, always remember sternum and shoulder to be straight. So what happens? You need to give the chest compressions at 100 to 120 per minute, 30:2 ratio, that is 30 compressions, 2 breaths. Nowadays modified to 15 compressions, 2 breaths. Chest compressions very much required for giving a proper CPR. Now, defibrillation AED, if it is available, always remember the first 5 minutes, maximum to first 7 minutes. They are the golden period. and it is very, like, very important that if you have an AED inside, you can save the patient if you do the CPR properly. So please remember, for CPR, the heel of the hand should be on the lower sternum. Your shoulder should be on the sternum. The shoulder should be on the sternum. Compression, as I told you, you should, for adults, it will be 15 compressions to breaths. Compression, if you can do 100 to 120, nothing like it. Minimum 80 to 100 need to be done, 15 is to 2, 30 is to 2, depending on the situation. And as I said, the golden period is generally 5 minutes. This is the time. CPR success is always related to the time. So please remember, heel of the hand on the lower sternum, shoulder on the sternum, and you will give the cardiopulmonary resuscitation. Every 2 years, you should do these courses annually in order to, basically make you better to combat any emergency. And these are the management positions. For a quick recall, so commonly just remember sport. Stop with the procedure, position, oxygen, ABCs, check the ABCs, reassure and take vitals, do the treatment, call the ambulance. So for syncope, broadly, it is position. Position is Trendelenburg. Oxygen, stop the procedures. You can, give spirit of ammonia to revive the patient, nil per oral. Yeah, so this is position for syncope. For hyperventilation, just try to reassure the patient, talk to them, allay their anxieties, give a brown paper back so that they can take in their own CO2. For anaphylaxis, airway, keep it patent. You have to prevent the tongue from falling backward, tongue from sticking to the oropharynx. You have to keep the airway patent. You need to inject an epinephrine IM. And for aspirations, just prevent it from happening in the first place. Use a rubber dam, use those ligature, use instruments, use floss, the floss, be careful. In cardiac patients, I have told you what you need to do. ONA, MONA, please remember these two mnemonics, very important for angina and MI. For seizures, again, stop the procedures, let that seizure occur, just keep the patient safe, ensure that they're not aspiring on the fluids. And an emergency kit, you need to have an oxygen, you need to have the extracting airways, you need to have all your medications, which we have discussed. You need to have glucose, all the emergency 108 numbers, nitrous oxide. So yeah, these are the various exam tips. You need to remember all the mnemonics. So again, you can pause this slide. Remember that syncope is the most common emergency. Vasovagal syncope is the most common of all. Epinephrine is it's the best life-saving drug out there. It is epinephrine can be used for so many of the medical emergencies. Pathophysiology of each emergency has been discussed in details. So master these mnemonics, keep the sport mnemonic in mind, go through the slides. I hope you had a good time. These are again the typical exam exam questions, which, they can ask you in a viva or a chair setting. So again, you can pause this slide. Just for example, just see answer question 4. They are saying the epilepsy lasts for 8 minutes. That means it's beyond 5. It's status epilepticus. What is the difference between angina and MI due to the imbalance? It's irreversible and reversible. Patient develops urticaria, dyspnea, hypotension within 2 minutes of a penicillin injection. They're talking about anaphylaxis. You need to give an epinephrine 0.3 to 0.5 mg IM as soon as possible. The patient has become very restless. There is tingling in the lips. He's having that pin and needle sensation. That means, the hypocapnia has occurred. Respiratory alkalosis is there. So hyperventilation is happening. About syncope. We have discussed about syncope in detail. So you can again pause this slide. Various viva questions, management, the exact dose can be asked. Now, other than that, as a doctor, always remember, stay calm and composed. If you panic, the patient will definitely panic. Be confident, have a steady voice, keep taking deep breaths, do not panic. Give clear instructions to your people in the clinic, to your patient. Also, keep reassuring the patient, build a positive rapport. Document everything for your safety too, from the time of onset to the symptoms, to how the vitals were taken, what did you do, what medications you gave, within how much time you called the emergency services. Also, whenever such an emergency happens, please do the follow-up, inform the hospital records, and keep explaining what happened. So thank you. This was a wonderful experience. I hope you guys also took well from it. And on behalf of Dental Desk, thank you so much. Jai Hind. Thank you.